Good morning to everyone. My name is Daniele Battelli. I am an anesthesiologist living and working in San Marino in pain medicine and palliative care. And I am also here as a representative of the European Federation, European Pain Federation ethics. So I will bring to you all the thanks and greetings from San Marino Republic as well from EFIC. And thank you very much to Dr. Apostol Vaso and all the Albanian Pain Society for having invited us to this really intriguing and interesting event. We have some issues, I think, with the sound, but now it's okay. Okay, thank you very much. So we will have a little speak about spinal cord neurostimulation in the treatment of chronic pain, chronic neuropathic pain mainly. The journey of neurostimulation is born when two scientists, Ronald Melzack and Patrick Wall, had the idea and developed the famous gate control theory. This was a theory by which there were inhibitory interneurons between the afferents that could regulate and modulate pain sensation and nociception. This was the first insight into something electrical that could be theoretically modulated to achieve pain control in chronic painful conditions. And so this was the idea that has been taken by the first scientists who tried in the clinical reality with a real clinical application, Norman Shealy, in 1967, with the first implantation of an electric device near the spinal cord, trying to verify if it was true that stimulating electrically the spinal cord could bring to a reduction in nociception, so could bring to a reduction in pain. And he began, now we are all used to think of neuromodulation for neuropathic pain, but he began in a patient with a terminal pulmonary metastatic disease, so in a pure nociceptive pain, almost pure nociceptive pain condition. What is a spinal cord neurostimulation? A neurostimulator is an implanted device, a neural pacemaker, a true neural pacemaker that is implanted through a percutaneous catheter that is inserted via the epidural route near to the spinal cord at the usually thoracic or cervical level, or via a surgical implantation in case of special electrodes for patients that have anomalies, or other difficulties inserting a percutaneous catheter, so that have to be implanted using a surgical laminotomy technique. So it is something that is not an injection, is not a drug given orally, but is a system that has a high cost, that is something that the patient can bring with him for the life. And so it is something that has to be well evaluated, that has to be well addressed for both the clinical indication as well the patient characteristics to obtain the most of the results from this technique. And technically, this is how you see during an implantation the insertion of the electrode under X-rays. You have to place one electrode near to the spinal cord at the dorsal level of the vertebral column, medially, and on the dorsal aspect of the spinal canal to reach the neurostimulation of the dorsal afferents into the spinal cord. So we have to think that we still don't know exactly what and if there is one or how many mechanisms that make the spinal cord neurostimulation work. Many studies have been in the years during the development and the clinical development of spinal cord stimulations. Many changes have been made also in the neurostimulation itself because the waveforms of the electrical stimulation has changed a lot, and the paradigms of neurostimulations has changed a lot during the last 30 years mainly. And so in that way, we have also had many hints that a lot of different mechanisms underlines the efficacy of an electrical stimulation of the spinal cord for achieving chronic pain control. We have segmental effects, so we have one effect near to the spinal segments where the electrodes are implanted. There is a postulated selective C-fiber activation that it's more or like what the gate control theory was postulated for. There could be a desynchronization of a firing of the continuous afferent stimulus that is reduced by the spinal cord electrical stimulation, but there could be also changes in the ion channels and local cell modulation that could be induced by the continuous electrical stimulation that is transmitted from the spinal cord also proximally. And so not only segmental spinal effects of a spinal cord stimulation exist, but many others have been postulated, have been tried to be verified experimentally, but what we know now it's that at least with some paradigms of electrical spinal cord stimulation, the analgesic effect that we achieve is even linked to supraspinal effects that are enhanced and are stimulated by the stimulation of the spinal cord at the dorsal column level. Particularly, there is an increase of the descending inhibition at the rostroventral medulla level or the periaqueductal gray. There is also a secondary cortical inhibition of pain perception in what is called the pain matrix at the cortical level. So there have been different demonstrated supraspinal effects linked to efficacy of the spinal cord stimulation for chronic pain condition. As we say, that the techniques for the implantation may be different, even because we have many different potential pain conditions and also anatomical differences. For example, there could be patients for which the implantation of the electrode into the dorsal column is not achievable because they have had lesions at the spinal cord level that could be the cause of their pain, so you cannot physically implant a percutaneous electrode into the dorsal column. And so you have mainly two ways to achieve and to get to the spinal cord with your electrode. That are those thin electrodes, catheters that you see on the right and left sides of that image, that are catheters that are inserted through an epidural puncture percutaneously. But you can also have those leads that are wider and that are sutured to the dura mater in front, in the epidural space, through a surgical laminectomy to place your electrode in a firm and stable position onto the spinal cord for stimulation. Those systems obviously require a more invasive neurosurgical intervention through, as we said, a laminectomy. And technically, there are a few paradigms for neurostimulation that are applied today, apart from the waveform paradigm that you will use for treating the chronic pain condition with the spinal cord stimulation. The first is that your electrode should be implanted in an anatomical region of the spinal cord that is coherent with the pain phenotype that you are treating. So, usually, the electrode tip should be located at the T8 level for the chronic low back pain and lower limb pain, or to the C2 to C5 level for treating a pain in the upper cervical or upper limb region. The lead stability is one of the most important factors when you apply a technique for spinal cord neurostimulation, because as we have seen, the surgical leads are sutured near the spinal cord, so they are not able to move from where they are, but the percutaneous electrodes can be intrinsically unstable, so they have to be anchored to their emergence to the fascial plane to avoid them moving and to avoid them displacing, losing efficacy of the neurostimulation. And the last one criteria is that you have, through your stimulation, be able to have an anatomical concordance from the paresthesias that you are able to evoke, activating the stimulation through your electrodes near the spinal cord, and the pain topography of the patient. So when you undergo an implantation, you put your electrode, you activate it testing for the territory where you evoke paresthesia in the patient. You ask the patient, where do you feel tingling or paresthesia in your body? And those territory should cover the pain field, the pain area for the specific patients and the painful condition that you are treating. As we have said, we have many different potential ways to stimulate the spinal cord during an electrical spinal cord stimulation. When a spinal cord stimulation was born in the first years, we only had the conventional tonic spinal cord stimulation that was neurostimulation at a frequency of about 50 to 100 or 150 hertz to make the patient feel a paresthesia sensation, so tingling in the painful territory. And that was the very first system for waveform generation for spinal cord stimulation that has been used in clinical practice. Then, in the following years, many different paradigms have been studied, and some of them have been applied to the clinical practice, mainly two that are burst SCS, that, as you see here, are train of pulses intervened by pauses in the neural stimulation, or the most recent waveform stimulation, the high frequency neurostimulation that is traditionally considered the stimulation from 1 kilohertz and above, that are each one being able to have efficacy on different pain phenotypes, and probably to be able to activate different ways or different effects, as we have seen that there are many possible effects for the efficacy of the spinal cord neurostimulation, like the segmental or supraspinal effects into the spinal cord, the brainstem, and the cortex. So when you treat a patient, you are today able to apply, in some cases, all these different waveforms at the same time in the same patient to be able to intervene on different pain phenotypes or to modulate, to tailor your neurostimulation to the specific patient to gain the best of the results. In the years, many different clinical indications for the spinal cord stimulation have been proposed, studied, and have gained popularity or common acknowledgement for their indication. Globally speaking, inclusion criteria for a potential candidate to neurostimulation is the presence of chronic neuropathic pain or ischemic pain syndrome that has an insufficient response with the conventional medical management in a patient that is willing to have an implant and that should be able to cope with implantation and to cooperate with the medical team that will have him or her in charge during the follow-up periods. The most common indication, the one that has the most of the literature as of today, is the what was called the failed back surgery syndrome, that today is called the persistent spinal pain syndrome type 2. That is a patient that underwent a surgical intervention in the spine, usually the lumbar spine, even if also a failed neck surgery syndrome exists, that has a persistent or a new onset of low back and radicular pain and pain symptoms that are not candidate to further surgery. And this is the principal indication for the spinal cord stimulation, where we have now good evidence of efficacy of the neurostimulation, particularly if we compare neurostimulation with the potential alternatives that we have for that specific patient, because we all do know that spinal cord neurostimulation is not a saint grail for the pain control in chronic pain patients, but we have also to measure this costly technique, this invasive technique, with the alternative that a patient could have in front of a chronic painful condition of that specific kind. So those are patients where drugs often don't work or work only partially with side effects. Patients that have not or where surgical reintervention could potentially be more dangerous than a mini invasive or small interventional like neurostimulation. So we have to weight the risk and benefits for each patient in front of those chronic painful pain conditions. And the other one is the complex regional pain syndrome that has a weaker recommendation than the failed back surgery syndrome, but where at the same time we face a painful and really disabling chronic pain condition of a neuropathic origin, where drugs and conventional conservative treatments many times are not able to bring to a sufficient pain control. Painful diabetic neuropathy is one of the emerging, particularly in the last years, with the efficacy on painful diabetic neuropathy of the most recent neurostimulation paradigms like high frequency, is one of the big new indications of the spinal cord neurostimulation that has been demonstrated to being able to give the patient achieve a good result, a good a good result not only on pain intensity but also on all other quality of life items at 6 months and also at very longer intervals. We have now studies that go well beyond the 2 years of follow-up and still demonstrate to be able to maintain a good effect on pain and function in patients with painful diabetic neuropathy. And not only on these phenotypes, but as we have seen also in other challenging pain phenotypes, like phantom pain, neurostimulation can be a potential alternative. Like we have seen from the Marshall Devor presentation, the dorsal root ganglion is a key role player in the phantom pain. But what we will see also from Suleiman Ozialcin later, the dorsal root ganglion stimulation in phantom pain could be one selective way to achieve pain control acting on a specific dorsal root ganglion instead of stimulating the entire spinal cord. And clinical data show that the DRG stimulation could be superior to the traditional spinal cord stimulation in phantom pain patients. And the dorsal root ganglion could be the target also for the postherpetic neuralgia patients where the pain is generated on a very specific, usually single radicular dorsal root ganglion that has been infected by the relapse of the varicella zoster virus. One of the key issues in the neurostimulation of postherpetic neuralgia that we mainly face patients with allodynia where the traditional paresthesia waveforms can be unpleasant or give an unpleasant sensation to the patient. So for those particular conditions, the high frequency stimulation could be more valuable to avoid avoiding the neurostimulation just because the traditional paresthesia paradigms add unpleasant sensation to the patient that also had a cutaneous allodynia. And one still emerging consideration, now that we have many waveforms, now that we have implantable systems that are evolving every day, is if we do know that in some patients we have a little expected benefit from a surgical intervention with potentially an invasive procedure, why don't we try and see if neurostimulation could be an alternative for patients that are the so-called virgin back patients, so patients that have persistent spinal or radicular pain symptoms, but that are not candidates or do not want to undergo to surgery. And also in those patients, and also in our clinical experience, those patients are sometimes also less complicated in the like disability, like all other factors linked to chronic pain conditions, and achieve good results, may achieve good results with spinal cord stimulation. So also the study demonstrated that different paradigms, both closed loop neurostimulation, that is a particular form of neurostimulation that adapts to the distance from the electrode to the spinal cord, as well as traditional neurostimulation versus conventional medical management, can be valuable alternatives for patients that have persistent spinal and radicular pain that are not able or do not want to undergo surgical procedures. There are meta-analyses now that are confirming those good results, so there could be patients where you could question in front of a chronic radicular pain if you should choose a neurosurgical intervention or a less invasive way to achieve pain control. Ischemic pain syndromes have been one of the first clinical indications for neurostimulation and are particular conditions where neurostimulation provides not only pain control, but is also able to reduce the time to amputation or reduce the risk to amputation, ameliorating the peripheral oxygen perfusion through a vasodilator effect, a sympathicolytic effect of the stimulation of the dorsal column of the spinal cord, being a really valuable alternative for or a complement to therapy for patients that have a symptomatic ischemic limb condition with ulcers and pain and that are not candidate to reconstructive vascular surgery. There is today a Cochrane review of efficacy for spinal cord stimulation in ischemic limb syndrome, and this one of the conditions where spinal cord stimulation is able to offer patients one of their best results. So, we have seen that we have many potential indications to suggest or to think for our patients when could be the case to think to spinal cord neurostimulation or to think to dorsal root ganglion neurostimulation for treating a chronic pain condition. But since this is an invasive procedure, a really expensive procedure, we should try to anticipate the best which patients will be the one that will mostly benefit from what we could offer to them. And we have now today many different meta-analyses and studies that have been able to predict outcomes for indication to neurostimulation. Mainly, we should know that neurostimulation is usually good and is usually appropriate for patients that have not only low back pain, but that have mostly or even radicular symptoms in persistent spinal pain type 1 or type 2, and that have peripheral neuropathic or neuropathic-like pain and conditions like the painful diabetic neuropathy or ischemic pain conditions. But we should also anticipate the psychosocial factors that could make our implantation of a spinal cord stimulation a success or a complete catastrophe. Evidence is constantly emerging and growing about the fact that the psychological profiling, the psychological risk factors, and the psychological evaluation of the patients that should undergo an implantation of a spinal cord stimulation system is of paramount importance because there are many variables, there are many psychological factors, for example, the pain catastrophizing attitude that are linked to a worse outcome of a spinal cord stimulation implantation, or other social aspects like, for example, patients that will not be able to deal with the technical aspects that are not very difficult but are present of dealing daily and constantly with the spinal cord stimulation device, like for example, just how to use the system for their charge in the evening, or just to using the remote controls to adjust the neurostimulation once they have the system implanted. So the trial implantation is one of the keys to understand if our indication for a specific patient has been a good idea or not, is a period where we implant only the electrode in the patient, a period that lasts usually from 1 to 4 weeks, that is meaningful to understand how the patient ameliorates not only from the physical NRS pain scale side, but also from the disability point of view of the daily activities of his daily independence, ameliorating his pain condition, and is the moment where the patient experiences the neurostimulation itself and understand if those treatment is something that is really something that is able to give him not only pain relief but also a better quality of life in a wider sense. The paradigm of selection is so based on a thorough multidisciplinary evaluation of the patient, but also could be based on screening tools that are today available for the clinician to have a scale of a predictive positive outcome value for that specific painful condition, from the clinical aspects to even the psychosocial aspects and factor for that patient. There are today's those screening tools that tell you if the patient could have a good result, is expected to have good results with the neurostimulation. There are many studies that try to understand the risks and benefits of directly implant the full system, not only the trial electrode, but also the generator on the first surgical time. That is called the direct to implant technique. That is a viable alternative today for patients that have a really good, a really high predictive score for efficacy of neurostimulator, and for example have risk factors for infection during the trial phase, like for example diabetic patients, or that have risk factors linked to the continuous suspension and reprise of anticoagulation medicines, like could be for example a patient with ischemic limb pain. So direct to implant technique is viable and is an alternative for selected patients that have a higher expected outcome from spinal cord stimulation. So take a message. You shouldn't think of spinal cord stimulation always and for any reason at the last stage. There are many conditions that we know that could have a good result, and we have good evidence on for trialing spinal cord neurostimulation, and sometimes reaching the patient earlier is best before he loses quality of life, he loses ability to cope with deal with daily activities. The use of predictive tools is really useful for us to understand if we are thinking to a spinal cord stimulation system for the right patient. The waveforms should be matched to the phenotype, because as we have seen, many different waveforms are able to evoke different pain relief mechanisms in the spinal cord and at supraspinal levels. And the patient should always be treated within a biopsychosocial framework to analyze not only his physical reporting of pain, but also his psychological and social aspects that could make a big and huge difference between a patient that has a very good result with an implantation of those complex systems, or a patient that is not the right patient for this technique. Thank you all very much.